Hello, everyone, and welcome to this episode of the Fortcast, the official vodcast of Fort Healthcare. I'm your host, Dr. Michael Anderson, President and CEO of Fort Healthcare. And with me today is a very special guest, our cardiologist, Dr. Raaid Museitif. Dr. Museitif, thank you for joining me on this episode of the Fortcast.
Hi, Dr. Anderson. Thank you for having me back. I appreciate it. Always look forward to these.
Well, we love having you. And today we're going to be talking about strokes, which I'm excited to learn about because I always learn in talking to our guests here. But before we get started in talking about strokes, Dr. Museitif, how long have you been with Fort Healthcare now?
Well, Mike, it seems like, I don't know why it seems longer, but it's not bad. It's gone by quick. It's been over 2 years, 2023 that we started, more than 2 years, probably about 2.5 years that we've been here. Like I've said before, I'm from Wisconsin, born and raised, and I went to med school at UW-Madison in undergrad. And we've been here starting some great programs. So I appreciate all Fort Health and the staff and yourself for making our whole department possible.
Well, we appreciate that too. Yeah, we're both proud Wisconsin alumni, and it's wonderful to have you on the program. Today, I want to talk about stroke. And there's so much information out there on stroke. And I think it's just a really wonderful topic to address to our patients and community. Dr. Museitif, let's just start with a definition. What is a stroke?
So typically what people think when they have a stroke, they can imagine someone who's just paralyzed, they can't move, or they can't talk. That's what, if you visualize a stroke, that's what we think about, or at least that's what I've always thought about. Well, how does that happen? It has to do with our brain, obviously. Our brain controls all of our nerves, our muscles, our movements. And when part of our brain gets affected, either dies or temporarily gets paralyzed, whatever area that brain controls of our body, we lose that control. And that's essentially what a stroke can happen. Now, there's different ways that your brain can become damaged. It could be traumatic. You could have a gunshot wound or injury that can damage the muscle. And then that can give you a paralysis or discontrol of your body or of your thought, even the way your brain functions or your vision or your speech. But mainly when we think of strokes, we divide them into two broad categories. And those are called hemorrhagic strokes and ischemic strokes. And these are fancy medical words for hemorrhagic is a bleeding stroke. So if any of your blood vessels start to bleed inside your brain, and let me just step back, because your brain, obviously, it's hard. Some of us are more hard-headed than others, but that's me. No, I'm just kidding. But because of our skull.
That's a whole separate vodcast.
That is.
Yeah.
But because we have our skull and our brain sits in the skull, our brain is so important to the human body that it's really the only thing that we've encapsulated in this very strong bone. But the downside of that is it is a pressure ball, almost like a pressure cooker that you have. And so any change in the volume can really affect the pressure. And so we have blood vessels going to our brain to feed it with oxygen and nutrients. And then we have drainage system to take that blood back out and recycle. And you've heard of people who have aneurysms. An aneurysm is just a tube that has, like when you do the clown balloons, they blow it up and then in the middle it gets really big like a ball. Well, when you do that, the wall, in physics we call that shear stress, it gets really taut. And you can imagine if I had one of those clown balloons, if you hit the ends of the clown balloon, they're very floppy and flexible. They're not that stretched out. But in the middle, it gets real taut. We call it shear stress increases, and it gets real tight. And if you just touch it, it could pop the balloon. And in our brain, those things can happen. Or from I fall down and hit my head, I can cause some bleeding internally. That will increase pressure and kill that area or damage that area of the brain. And that would cause a stroke, a hemorrhagic stroke. That's a bleeding stroke. The majority of strokes are not bleeding strokes. There are the other category called ischemic strokes. And ischemic strokes are very similar to how all the blockages in your arteries happen. You can think of the arteries in my brain just like a tree. There's the big ones in my neck, like the tree trunks. And then all the arteries kind of fan out and they're smaller and smaller and smaller. And so of the ischemic strokes, there's two broad categories. We call them embolic and atherosclerotic. And the atherosclerotic is just a plaque that builds up in us as we age. So you can get plaque built up in your carotid arteries, and that's like the trunk of the tree. And a little piece of plaque can break off. But when a little piece of plaque breaks off in something as big as a trunk, it can just float through the tube and float through the tube. But then it might come down my little pinky, and it might get stuck at the tip of my pinky. And that just represents a little blood vessel there. If it gets stuck at the tip of the pinky, then everything below that blockage, doesn't get any blood, and that could cause a stroke. Those are atherosclerotic. You get blockages from plaque buildup, and that's the same process that would have plaque buildup in your coronary arteries that would cause a heart attack. That's the same process that would have plaque buildup in your legs that would cause peripheral arterial disease, or in your kidneys and cause kidney damage, or everywhere else. Now, under that ischemic stroke second box, one is the atherosclerotic, the other one is called embolic. And embolic is sometimes something can break off, or a clot can form someplace and float up and do the same thing that little plaque could do. So some people, you've heard of the term atrial fibrillation. It's an irregular rhythm. And a lot of those strokes happen from that. Blood clots can form in the heart, and they can break off and embolize. That's a fancy word of leaving one position and going to another position. Distally, it could break off from the heart and go up to our brain and do the same thing that little plaque did, go up and just boop, clot off an area of your brain. So in essence, a stroke is when one of the areas of the brain is affected, and it results either transiently or permanently in the loss of function, feeling, control of our body. And that can happen from different mechanisms: bleeding, trauma, aneurysm rupture, atherosclerosis, or embolic.
So I want to get back to something that you mentioned, and that has to do with the embolic or stroke. So basically, a stroke is when the brain tissue gets extremely damaged, and there's two major ways that it happen. Either a blood vessel can rupture in our brain, cause brain damage, or the brain tissue can't get blood supply, like from a clot that happens in the blood vessel itself. So you mentioned a little bit about atrial fibrillation, and how does predisposing conditions in the human body, or in the example you use, the human heart, predispose people to potentially getting a stroke where they have actual tissue damage in the brain?
Yeah, that's a great question. So these recommendations that we have, or the risk factors, are the same for a lot of health problems in our country, in our state, all that. So atherosclerosis, that plaque buildup, sometimes it can be genetic, is one factor. Now, there's no one answer. A lot of times, this is what we call multifactorial. All these things can add up and increase your risk of developing plaque. That includes inactivity. Let me tell you, walking an additional 30 minutes a day. So I said inactivity, meaning you're not exercising. But whatever you're doing now, even if you're measuring your steps and you tell me I get 10,000 steps a day, that's great. But if you added 30 minutes in total for an entire week, that's like 6 minutes a day, or whatever the math is, less than 6 minutes. Decrease the likelihood of you having a heart attack, stroke, or dying by 14%. So lack of exercise causes that. High cholesterol and not getting it treated. So in America, half of the people who have high cholesterol are even tested. And then of those who are tested and have high cholesterol, only half of those are treated. And of the half that are treated, only half are treated to goal. So inactivity, high cholesterol, high blood pressure. Hypertension can lead to both hemorrhagic strokes and development of atherosclerosis. And knowing your blood pressure, getting it treated, and getting it treated to goal. Obesity can cause more inflammation and damage, and all those things that we did. Lowering your BMI, your basal metabolic index, and getting in shape, and eating healthy fruits and vegetables. So we say 5 of the fruits and vegetables a day. They decrease your likelihood of having an incident by like 1.7%, like almost two times less by eating healthy. So diabetes, high cholesterol, obesity, inactivity, smoking, genetics, and exercise. Those are all things that you can do that are better than seeing me.
There's a lot of factors that go into it, and certainly patients and definitely have to work with their primary care providers to prevent the longitudinal long-term effects that can lead to a stroke. One thing I want to ask you about, Dr. Museitif, is we hear a lot of times you hear the term mini stroke or TIA. Can you tell us a little bit about what a TIA is versus a traditional stroke? Can you take us through that nomenclature?
Yeah, so those same symptoms that we talked about before, whether it's a speech problem, whether it's a control problem, you have weakness in your arm or leg, you can't move it, whatever the neurologic deficit of a stroke is, the difference between what we call mini stroke, but the medical term is transient ischemic attack, versus a full, what we would call a cerebral vascular accident, has to do with the amount of time that those symptoms were present. So when you and I trained, it was 24 hours. If the symptoms lasted less than 24 hours, we would say that's a transient ischemic attack or a mini stroke. If your symptoms lasted longer than a day, we would call that a full stroke. Now it's as little as hour to 3 hours, we would call that a mini stroke. If it lasts longer, we start to say it has a stroke. The other thing that we used to say is when we do a CT scan or MRI of the brain, if you have a neurologic complaints but no lesion, we can't see a stroke on the MRI, we tend to say that that's a transient ischemic attack or a mini stroke. If we do an MRI of your brain and we see a spot that would indicate death of muscle, we would call that an infarct.
I want to touch base on what tools do we have to determine the site of a stroke besides just the symptoms? Because obviously, if one part of the brain isn't getting oxygen, we're going to have symptoms in our extremities. But what tools do we have to try to diagnose where the stroke is happening and if there is a stroke? And I think you just touched on that.
Yeah, that's a great question. One thing for our listeners is that a physical examination and a history by your provider is very accurate to see if you're having a stroke. The next step that we do is imaging. But there's reasons why we do imaging. One is to confirm it, but also, remember I told you before, you could be having a hemorrhagic stroke, which is a bleeding stroke, or you could be having an ischemic stroke, which is a blockage stroke. We really want to know if you're bleeding in the brain. So the CT scan, a CAT scanner, some of you who are listening have had that. That's just a little tube that you lay down in there and it scans your head really quickly. It shoots out these little photons, it comes back at us, and our computer an image of it can tell us it's really good at seeing strokes that are old, and it's really good at seeing bleeds that happen right now. It's not as good at just seeing an ischemic stroke that's not a bleeder, that just happened acutely. So when you go in the ER, we right away do a CT scan. And the reason why that happens is there's something, Dr. Anderson, that's called the golden window. And so we want to know within an hour and a half, really 90 minutes, and sometimes we've extended that now. If you're having a stroke and you have a deficit, we can get to you very quickly. Do a CT scan and make sure you're not bleeding. We can give you this medicine that's literally like liquid Drano that can go in there and bust up that blockage and restore flow, called TPA or something else, some other drug that they give you. So in the emergency room, you're having symptoms. Anytime anybody has symptoms, they should call 911. Based on your symptoms, they'll already start to raise alarm bells with your medical community. They'll quickly do a CT scan, make sure you don't have a bleed. And if your symptoms persist, they'll make a decision right there with their stroke team to give you that potentially a life-changing, life-saving medication. And that's where the CT scan is. Now, sometimes your symptoms have gone, we've done a CT scan, there's no bleed, we don't see a spot. Then your doctors sometimes will advance to a different type of head scan called an MRI, magnetic resonance imaging. That uses a different mechanism to visualize tissue, and the MRI is the best test to see an ischemic stroke that just happened.
That's very encouraging to know that if an ischemic event is seen, that we can offer patients that time-sensitive medication that can make a huge difference in the care of that patient. If somebody has a stroke and they have long-lasting symptoms, Dr. Museitif, are there treatments for that?
Yeah, we hopefully, just like you said, we do have hospitals just like ours. I mean, there's protocols for stroke, that it's really time-sensitive, that we have a plan on how to treat you. They can get you, if the blood thinner doesn't work, they can get you to different institutions where there's something called neurointerventionists. They can actually go up there and put a stent-like substance to actually just pull the clot out and hopefully prevent some of these symptoms from persisting. Sometimes that's not possible. Sometimes the bleed is hemorrhagic. Sometimes you have persistent stroke symptoms. That's just part of life. So what do we do about that? Well, your team is going to want to know, first of all, why it happened, so that we know, hopefully, what we should recommend to prevent it. And then number 3, medications and therapy and really working with your entire medical team with occupational health, physical therapy, occupational medicine to help restore some of that control. And the amazing thing about our brain is sometimes certain areas may have been injured, but other areas of brain can help take over those functions. Kind of like football. One of your players gets hurt, somebody else comes in, and your brain does the same thing.
Well, it sounds like there is a team in place, a rehabilitation team, a rehab team that can take over and help patients that have those more permanent stroke symptoms that can really be helpful in the recovery of that patient. Is that correct?
Absolutely. Yeah.
Absolutely. Well, I like to hear that.
You have to have a whole system to do it, and we do.
Gotcha. Well, Dr. Museitif, I want to say thank you for teaching us a little bit, or some would even say a lot of bit, about strokes today. I always learn a great deal when I talk to you, and I learned a lot about strokes today. So thank you for talking to us about it.
Oh, I appreciate that. And I just want to add one more thing that you had kind of touched on and I didn't explain. And a lot of people who ask about strokes, they also tie it into atrial fibrillation. So that's an arrhythmia that most people, if they live long enough, are going to develop. And a lot of people are listening to this, they either have atrial fibrillation or their spouse or one of their family members. And in atrial fibrillation, the top of the heart just quivers. It never actually squeezes. And the way your body is made is you actually have, for better description, you have a love handle that hangs off the top of the heart. And when you go into AFib, normally the heart squeezes from the top and pushes the blood into the bottom, and then the bottom of the heart squeezes out. But when your top of your heart's not moving, all the work is from your bottom. Your bottom opens up and sucks the blood down and then pushes it to the rest of your body. But in that little love handle on the top, the blood just sits there. And when the blood just sits there, it's just like when you cut yourself. If you squeeze your hand, you can keep making it bleed, keep making it bleed. Every time you wipe it, like when you get a shave and I got so much toilet paper on myself. But if the blood just sits there, it clots. And in atrial fibrillation, the blood will clot in that little love handle and it can break off. And when it breaks off, it goes to your brain. And that's why people are listening. Your providers put you on blood thinners because that helps prevent whatever blood sitting in that little handle from forming a clot and breaking off, and just how we described it today, going up and causing a stroke.
Well, I tell you, I like that little teaser on atrial fibrillation because I think that definitely can be a future topic on the Fortcast. But that's very well explained, Dr. Museitif. Yeah, atrial fibrillation is so common in the population, and I look forward to perhaps having that as a separate vodcast. I think that's a wonderful topic. So thank you.
Appreciate it. Thank you.
Thank you, everybody, for joining us today to talk about stroke. Thank you, Dr. Museitif. And please don't forget to share us on your social media platforms. And also, please check out our library on our website. Again, this is Dr. Michael Anderson saying thank you and have a great rest of your day.